So we'll come back with questions after, but first I'm going to hand over to T.S. Kroezen from Philips. Thank you, T.S.
Okay, thank you, Simon, for facilitating, and thank you to the Academy for inviting me here. I was asked to talk about core competencies of private sector companies in global health, and I thought the best way to illustrate these core competencies is to come up with a concrete example. And I've chosen the example of the Philips journey in primary care, because that is a journey that I've very much been part of. Now, for those of you who don't follow the news on Philips on a daily basis, which I'm sure most of you do, Philips transformed from a diversified technology company into a focused health and well-being company. So those of you who know Philips for selling light bulbs, we no longer do. Those of you who know Philips for selling televisions, we no longer do. You can still buy those products, but they're actually being manufactured by others, no longer by Philips. So our business is health and well-being. And our journey started around 2010, when Philips defined its mission as improving people's lives through meaningful innovation. Now, that may sound very nice, but I think the company was brave enough to attach a concrete number to this. And the number chosen is that by the year 2025, as a company, we want to improve 3 billion lives around the globe on an annual basis. And we went even one step further. We asked our auditors to track this number annually. So if you take the annual report of Philips, you can find out how many lives we improved. And last year, 2017, it was 2.2 billion lives, which is a lot, but it also means we still have 800 million lives to improve between now and 2025. And when we did an analysis of where those 800 million people are, we concluded that we will not find them in the US or in Europe. We will find them in developing countries, specifically in Africa, because there we only reach 5% of the population currently. And that was the start of our journey into primary care. Because we said, okay, if we are serious about reaching people in Africa that we haven't been able to reach so far, that means we need to innovate, because apparently our products, our distribution channels are not suitable for reaching this part of the population. Oh, that was the wrong button. When looking at health systems in Africa, we quickly concluded that we should innovate with a focus on community and primary healthcare. Because I think we believe, and I think many people now believe, that that is the best place to strengthen a healthcare system. But unfortunately, at the same time, it's also the weakest part of most healthcare systems today. So we decided to start innovating for primary care. And in doing research into primary care, we learned that there are many challenges that primary care is facing, and I'm sure most of you are aware of them. So unfortunately, yesterday the word silver bullet was used. Unfortunately, there was no silver bullet, nice Philips product that we could develop that would solve all these issues. So we said, okay, instead of developing a product, let's develop a solution, a package that together should bring sustainable improvement to primary care and community care in Africa. And we decided to call this package Community Life Center. So what is in the package? And it's a modular package, so it's actually being adapted to the local needs and circumstances. It includes infrastructure. So we actually can design and build health facilities. It includes energy supply. Mostly we use solar there. It includes water supply, sanitation, lighting, so anything you need to create a properly functioning health facility. Of course, there's equipment in there, medical equipment, lab equipment. There's IT. In fact, most of our R&D work now goes into developing IT solutions specifically for primary care, because primary care has some specific challenges when it comes to the use of IT. And finally, services. So we bundle this all together with services so that we can do turnkey design, implement and support projects to make sure that we bring sustainable improvement to the primary care system in countries. We started with a first demonstration project 4 years ago in Kenya, in Kiambu County, just outside Nairobi. We now have 5 demonstration projects, another one in Kenya, 2 in South Africa and 1 in DRC. And these projects are demonstrating that if you improve the infrastructure, the equipment of a health facility, that actually has a huge impact on the quality and utilization of care. So we measure patient satisfaction, we measure staff satisfaction, we measure service utilization, and on all these we see very strong increases. So, because we're a company and this is a business for us, this is not CSR, this is not charity, we said that's great. We have developed a solution that works, so let's go and scale it. And that's where we ran into challenges around business models. So what we have learned over the past years is that when you want to scale this, you're going to run into several barriers. And so part of the work that we do is trying to come up with business models that address some of these barriers in order to enable us to scale this solution. So there is 3 models that we specifically use in a public setting. We also do this in a private setting, but I will leave that out for now. One is the more traditional model, what we call a large-scale project. It's a project with a scope, with a budget. We typically sell it to a government that in most cases is getting donor support to fund it. And we implement the project, the government pays the bill, and in most cases there is a couple of years of what we call a monitoring and support service that is part of the contract. That works in some countries, especially countries that still have large donor funding pockets available. But in a place like Kenya, that is working less and less because the donor funding is not there and the government has very limited investment capital. So they are not able to fund a large project like this. So the second model, and I think Nduku already alluded to it, the second model is what we call managed equipment service. And that was done for hospitals in Kenya. So we are now looking at, can we somehow translate that to primary care? Essentially what it means is we sell a service, not an asset. The ownership of the asset stays with us as a company typically. The government pays for the service through a fixed monthly payment, and we have certain performance targets to meet in terms of availability of equipment, uptime of equipment, those kind of things. So that's a model that has worked pretty well in Kenya for hospitals, and again we are looking at if and how this could be applied to primary care. The third model is PPPs, and as that is the topic of this session, I would like to dive into that model a little bit more detail. For us, a PPP means we take over an asset or a service from the government. We take a certain management responsibility, and the payment is related to our performance. So what we did is we have partnerships with a number of organizations, and one of our key partners is AMREF Health Africa, the largest Africa-based NGO. Interestingly, AMREF is transforming themselves into a social enterprise. So for the panel before, that's maybe an interesting thing to look into. And when we met with AMREF and we compared where are they strong, where are we strong, we said together we could probably run health facilities for a government. We reached out to Makueni County government, one of the 47 counties in Kenya, because they're quite progressive. And we said, what if we would improve and manage your health facilities for you? And the government was interested for a number of reasons. One is, I think that when it comes to improving their facilities, they have an issue with very limited investment capital. They can do that maybe for a few facilities, but they cannot do it at scale. So they were interested in, through a PPP, bringing private investment into their primary care system so that they could accelerate the improvement of their system. Secondly, the health minister, or the CEC as it's called in Kenya, admitted, he said, we are not good at management. So if these facilities were managed by the private sector, we expect them to operate more efficiently than they do today. So over the past year and a half, we've worked out a model with Makueni County government, AMREF and Philips, that we are actually going to start testing as of next month, July. What we're going to do is essentially 3 things. One, we are going to improve the system. So we as Philips, we're going to implement our Community Life Center package. We're going to improve those facilities, put in solar, put in equipment, put in IT, do all those things. But there's a lot more that we're going to do. In fact, there's a list of 15 interventions that we will implement. We're going to hire more workers, because there's a lack of workers. We're going to set up community health units. We're going to introduce IT systems that will give us information from the community. So there's a lot of things we're going to do aimed at improving the quality of the healthcare system. Secondly, outsourcing facility management. Now, in our talks with the government, we didn't go all the way and say, just give it to us and we will take full responsibility for managing these facilities. There are also some legal impediments to doing that. So we said, let's go for kind of joint facility management. So we are going to manage those facilities together with the county. And, well, we will learn exactly where to draw the line and where is the county responsibility and where is our responsibility. And thirdly, we know that if you improve the quality of primary care, your cost is going to go up. Because you're going to attract more patients, you're going to need more staff, you're going to need more supplies. So we are going to actually cater for that extra cost by developing new revenue streams. The main one being, and thanks to Nduku again for explaining the Kenya system, the main one being the national health insurance. So as part of this project, we are actually going to enroll people actively into the national health insurance, and the national insurance is going to pay us a $10 per year capitation fee for each person enrolled. Next to that, we're also going to introduce some additional services that are not part of the primary care package, for which people need to pay separately, either out of pocket or through their health insurance. So where does it bring me? First of all, I think we cannot do it alone. I mean, AMREF is a partner, but we have other partners. And also what I would like to say, coming back to what Ambassador Burke said yesterday, yes, I think as a company and as a private sector corporate, we have a lot to offer, but we are a company. So, and companies are very predictable animals. If you put a market in front of them, they will start running. So, my appeal to this community is, if you want companies to really engage, like I think we are doing as Philips, put a market in front of us and we'll run for it. Thank you.